This episode of The Curbsiders is sponsored by the American College of Physicians in celebration of National Internal Medicine Day on October 28th. ACP provides its 163,000 members with lifelong education, clinical support, practice resources, professional development, and advocacy resources.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Hey, Paul, we're back. Stuart's not here. Oliver is here, though, in his place. Oliver, of course, is your adorable black cat.
Yes, full name Oliver Pecan Paulford.
And this is the Curbsiders. To remind the audience, we have a partnership with VCU Health, and there will be CME credit available for this episode for free. You can go to curbsiders.vcuhealth.org. Paul, can you tell the audience, what is it that we generally do on this show? And then maybe you could tell them about our wonderful guest.
Well, thanks, Matt. What we generally do on this show is, why don't I tell the audience what we are instead? We are the Internal Medicine Podcast, and what we generally do on this show is we use expert interviews to bring you clinical pearls and practice-changing knowledge. As per usual, we have a fantastic guest, so the clinical pearls we bring to you are especially fantastic. We have Dr. Dink Jardine, who's going to talk us through her approach to sinusitis. We had a great discussion about her approach to acute viral rhinosinusitis, bacterial rhinosinusitis, and then we segue beautifully and masterfully into chronic rhinosinusitis. So we cover all the sinusitis disease, or whatever the plural of that would be. Shall I tell the audience a little bit about who our guest is, Matt?
I think now is a great time.
So Dr. Dink Jardine is a general otolaryngologist and serves as the Director of Professional Education and designated institutional official at the Naval Medical Center Camp Lejeune, where she maintains her clinical practice. She is a commander in the U.S. Navy and holds faculty appointments as an assistant professor in the departments of surgery and of pediatrics at the Uniformed Services University of the Health Sciences. She is passionate about medical education, especially procedural skills, and can often be found nerding out on teaching modalities and curriculum design. So without further ado, why don't we get to the nose? Do you have a pun for us, Matt?
I don't. I feel like Stuart almost certainly would, and we can all be glad that he has some sort of obligation this evening. The views expressed in this podcast discussion are those of the presenters and do not necessarily reflect the official policy or position of the Department of the Navy, Department of Defense, or the U.S. government. Okay.
It's going to be a good one.
Definitely going to be a good one. Dink, thank you so much for joining us.
Happy to be here.
We're excited to have you. Tell the audience and give the audience your one-liner and include some sort of hobby, something cool you're doing outside of medicine.
Oh, goodness. I hope that I'm doing things cool out of medicine, but sometimes that's not true. So my one-liner, I'm an over 40. I'm not going to tell you exactly how old. Female GME nerd. I'm a mom of 3 boys. I'm on my 3rd professional career, and I have a habit of starting at least one new hobby per year, and we'll talk more about that when I talk about failures, too.
Amazing. So many follow-up questions. Paul, I will let you go first.
Yeah, no, I think I usually ask about books, but I can't read anymore. So let me ask, and certainly you can tell me about a book that you like, but I want to hear about the careers first. So what were the first 2 careers before you've landed on this one?
So my first career was as a nuclear propulsion officer, which meant that I managed the nuclear power plant for aircraft carriers. And I did that for a few years. And then I was a stay-at-home mom for 3 years. And then I went to medical school and had my medical career. So this is my 3rd.
So I just want to mention, off air we were talking about your technological capacity, and I want to go back to the first. So you were saying you tended to break computers, and what was the first job again? I just want to make sure I was understanding things.
So just to be clear, I oversaw the management. And if you've ever been on any sort of military vessel, the technology is not cutting edge. So, yes, I can do computers, but I can't code computers, and that's okay.
Okay, so anything less than the level of nuclear submarine, you feel a little bit less than comfortable with, is what I'm hearing here.
Correct. Although back in the day, it was only the surface ships. So I was actually only on the aircraft carriers.
Okay.
Submarines wasn't available when I was on there. They are now.
Yeah. I wonder what's been more challenging, the raising three boys, the nuclear engineering, or being a physician. It sounds like you're up for any challenge.
They each have their own special challenges. That is a true statement.
Yeah. Well, unlike Paul, I do still try to read, although as Paul has said many times, the list of books is just towering. But I do go back to this list when I'm selecting a new book. So anything that you found useful or just entertaining, I'm all for escapism these days. So what would you recommend?
So I've recently come across a whole series, and I'll have to pull up the exact name, but I have recently become interested in crime fiction. And this is an older series that I just started, but apparently it's been around for years and years and years. But what's great about it is it's set in Canada and Quebec. And so there are all kinds of little nuances. So Still Life is the first one by Louise Penny. And there's a whole case series. So that's what I'm reading right now. But I mean, I have a growing list of Audible books that I just love and I pass on depending on what we're talking about.
Awesome. We had a previous guest, our Uncle Bob, who tells us that as internists, we should all be reading mystery because as an internist, it's our job to solve mysteries, which I actually like to think of it that way. It makes the job seem more exciting than sometimes it really is when I'm just refilling medications. So, Paul, any other questions you want to ask? Or I know we have a huge amount of things to ask, so...
Well, since it was alluded to, I do want to hear about your favorite failure. And if you wouldn't mind recapping what you learned
Sure.
from it, that would be great.
Yeah, so I alluded to it in my one-liner. I have this habit of finding a new hobby that I get super excited about. It averages about one per year. And generally, I will just throw myself into it. I will buy all the equipment. I will lay down we're going to go do this training and everything else. And some of them I stick with. So I turned 40 and I decided to start doing kickboxing. That one I stuck with and I still do it. A year and a half ago, I decided I wanted to do ice hockey. And after $500 worth of ice hockey equipment and a course, I discovered that I really don't like ice hockey because it hurts when you fall. And so what I've taken away from it is it's okay to go, I'm going to really get into this. And then when it doesn't work, I can tell people, you know what? It didn't work out for me, and I'm glad I had the experience. And when I first started doing these hobbies, I would be embarrassed by that. And now it's like, I just sort of lean into I'll try it and see what happens. But yeah, hockey was not my thing, at least not at the age of 45.
I'm just imagining that there must have been a Pogs collection at some point in your life. Or what are those sticks, Paul, that like people used to flip around at the beach and all that?
Oh, are those the devil sticks?
Yeah, devil sticks. Yeah,
Sure.
I'm just imagining all these past hobbies that you must have had, but.
A closet full of hacky sacks.
There's a closet full of mismatched toys and discarded paraphernalia. That is a true statement.
Wow, just amazing.
ACP wants you to help celebrate National Internal Medicine Day on October 28th. Share your internal medicine pride by spreading your I Am Proud message all year long, and especially on National Internal Medicine Day. I am proud to be an internist because it is a genuine privilege and an honor to help guide my patients through a complicated health system and to help them meet their own health goals. ACP provides easy, fun ways for you to celebrate at acponline.org/NIMD. You can download posters and a timeline of internal medicine milestones to share in your workplace or online. You can update your social media profile picture to include a National Internal Medicine Day frame, or you can customize and create your own posts, share social media posts from ACP and other internists, or just like and comment on ACP posts. Flood the internet with internal medicine pride on October 28th. Recognize a colleague and spread the love for internal medicine. Be sure to tag at ACP Internists and use the hashtags National Internal Medicine Day, hashtag I Am Proud, and hashtag I Am Essential. Visit acponline.org/NIMD to jumpstart your celebration.
Well, I think we should actually move on. Let's get to the case, Paul. And did you want to do the honors reading? I think we have some really fantastic names. I think we should really give credit to Beth Garbitelli for these, or are you willing to take credit for some of these, Paul?
No, none of them.
Okay.
These are all Garb's originals.
I thought you were going to say garbage, and I was going to say, how dare you?
I'm not saying. But let's start with our first case. So we're gonna start with Max Linus. Solid name, 28-year-old male. He's coming to us with a 1-week history of runny nose, and he's feeling pressure over his cheeks and forehead, and he's feeling this dull, waxing and waning headache, and just generally feels kind of crappy. He's been taking over-the-counter nasal sprays, though he's not quite sure which one he's been taking. He's been trying to relieve his symptoms, but none of them have been very helpful. He denies cough. He doesn't have any subjective fevers. He hasn't really measured his temperature at home. Doesn't have any other comorbidities that he's aware of. We take a look at him on exam, and he's got mildly inflamed nasal passages, but maybe he'll tell us what that looks like, because I'm not entirely sure. And then the posterior pharynx has clear mucus running down the back of it, and no exudate on the tonsils. The rest of the exam is unremarkable, or at least benign. So before we get into the case of poor Mr. Linus, that does not roll off the tongue, we always like to start basically with definitions and sort of define our terms. So before we get going, we're calling this a sinusitis episode, but there's also rhinitis and there's also rhinosinusitis, and I think that the papers that we've sort of read for background get a little bit wonky about it. Do you mind sort of talking us through the accepted terms and how we should be describing this collection of conditions?
Sure. So I'll do my best. I will tell you, just as you alluded to in the papers, we sort of flip-flop some of the terms and we use them interchangeably. The way I think about it is it's inflammation, right? So where is the inflammation? And rhinosinusitis is probably the most accurate term for what we're generally describing. When people say I've got sinus problems, they're usually describing a rhinosinusitis because the mucosal lining of the nasal passageways and the sinuses don't really have like a hard border where it's like, okay, this one ends and this one begins. So the rhino part is the nasal passage, the sinus part is the sinuses, and if they're all inflamed, it's rhinosinusitis. It is absolutely possible to have just a rhinitis, and so if you're not having any sort of significant sinus complaints, rhinitis is pretty, that's very accurate, and we'll talk about it probably a little bit if we talk about allergic rhinitis. Sinusitis is probably not as accurate because it's not common to have just an isolated sinus inflammation, although it's possible. And so that's how I sort of think about it. But rhinosinusitis is the accurate term. But again, as you've seen in all the papers, we sort of use them interchangeably.
And I just want to make sure I'm understanding. This feels like an SAT question, but most or almost all sinusitis has associated rhinitis, but you don't have to have sinus. You can have rhinitis without sinusitis, is what I'm hearing. Is that close to accurate?
That is pretty accurate. Yes, that is a somebody will find an example of something that is
would it make
different,
sense?
but those two will get you pretty far.
Because
but rhinosinusitis is, like we talk about chronic rhinosinusitis, CRS with or without polyps. CRS is the term we use, and so that's the more correct term. But again, there's not a hard barrier between the sinus and the nose, and so
it seems like it'd be hard for if you have something. The sinuses or the nasal passages are more superficial, and it's the first thing that microbes or irritants can encounter. So that's most likely going to be inflamed before it gets back into the sinuses, is the way that I would think about it. So it makes sense that it would be that can happen by itself. Well, is there anything from the history or the presentation that can give you a sense of like that you really pay attention to? And like for example, this case of Mr. Linus, what stuck out to you that would help you make the diagnosis just from the history?
So I spend a lot of time on history, and part of it is because patients will come to you as they come to me with, I've got sinus. Like that's what you get. And so you really have to ask more of the questions. For this particular case, the fact that it is a, week, less than 10 days, a very distinct, I've got congestion. When you ask about it, I've got a runny nose. I kind of feel just this general malaise. Those are all very telling of more of a viral acute episode, mostly from the timeline.
Yeah. So the physical exam here, they mentioned that he has inflamed nasal passages. I don't know if it's too soon to go into this, but if you're the primary care seeing this, before they just, refer to an ENT, what should they be doing on their physical exam?
So what I love is when folks look in the nose like all the time so that normal versus abnormal. for my purposes and when I'm teaching, like primary care residents who will rotate through, I have them use the otoscope, honestly, because the otoscope gives you a nice anterior rhinoscopy view. In the world of COVID, you're nice and close, which is, you have to take the appropriate precautions, but it gives you a nice view and it's lighted and you've got some magnification on it. But an inflamed nasal mucosa will usually be sort of this puffy reddish look. We often talk about boggy turbinates. Boggy turbinates are a little bit more of a purpley blue, and that to me is much more of an allergic look to it. But red, inflamed, sometimes they almost look sweaty because they're irritated. Oftentimes, if it's a pretty intense infection, you actually will have trouble passing the otoscope because it's just inflamed up to the point that it's touching the septum. And so those are the things that I look for like an inflamed nasal lining.
To do this, the otoscope, you put one of the ear speculum on there, and exactly. you tell the patient to tilt their head back slightly. And how far into the nose are we inserting this ear speculum? I don't want to hurt anybody.
So the thing that hurts, so when they come to me, I'm actually going to put a 6-ish centimeter camera in their nose, and so you're not going to hurt them with the amount that you can fit with an otoscope. What you want to do is you want to angle away from the septum because the septum is what hurts. So angle out towards the turbinate. If you need to touch something, turbinates really are pretty insensate, and you can touch a turbinate and get a pretty good view. I will actually tip the nose up a little bit, and I know you can't see this on a podcast, but I'm literally pushing my nose up almost like making a pig nose, because that helps you get the angle. And what you're trying to do is you're trying to look almost straight back and then slightly up, because the other place that you really want to look is in that middle meatus. So on the lateral side wall, you've got your inferior turbinate. Above that, your middle turbinate, and often you can see the middle turbinate just with an otoscopy. And if I can see in that middle meatus that there's purulence, that's going to be a very different picture for me than clear, because that's where we start crossing the line between viral versus bacterial. Wow. That may be more information than you wanted.
No, actually, I did not know that the turbinates were relatively insensate and that I should be veering away from the septum. This is all.
Yeah, don't touch the septum. we used to say, "Ouchie," says the septum. Ouchie.
That's the level of that's the level you should be working with Paul and I tonight.
So I guess, and we'll obviously get into this, but I feel like the initial question is always, is this viral versus a bacterial infection? Can you, in terms of sort of pointing towards viral etiology, sort of what about the rest of the patient? So obviously the temptations kind of go right up the nose, but what about sort of mashing on their forehead or pushing on their cheekbones or looking in their eyeballs? Is there anything else that's particularly high yield or especially useful in the physical exam to sort of point you or swing you towards a viral infection versus bacterial? Well,
so absolutely, an ocular exam will help you if you're, viral. You'll often get the conjunctivitis, not always. If you were going to have a complication of bacterial sinusitis, you absolutely want to do an ocular exam, but you're going to see that when you see them and things are puffed out. That's pretty obvious. That one's not subtle. I don't do a lot of mashing on cheeks or foreheads because it doesn't it doesn't help me much. There are a lot of people that are tender kind of no matter what you do. So is it part of our exam? Sure. Does it make or break things for me? Not really. Because for me, the story, the history, what their past either treatments have been is going to be a lot more helpful for me than, well, if I tap here, it hurts. I will tap on teeth, though. That is one place that I will tap to see if there's a dental etiology for it. And that one can be helpful because they'll go, oh, yeah, that really does hurt. And then you start looking at a dental etiology. But again, for viral, it's almost more the story and that I see this clear rhinorrhea.
So no transillumination?
You can transilluminate all you want. I don't know what I'm going to do with it.
Neither do
but you can.
Thank you. Thank you. But I actually, rhinoscopy, I will say, in primary care, I never really did it in residency, but then in primary care, I must have seen someone do it. And I just was like, I found it very useful. Like you said, it's like JVP or listening to heart sounds. You just have to get a lot of normals under your belt before you can see abnormal or you see enough and then you start to put things together.
Yeah, I kind of tell people, if they're coming in for anything else, look in their nose and look in their ears so you can see normal.
I feel like it also...
I'm biased.
Maybe we're getting away from the point, but I feel like it also lets the patient feel like you know what you're doing at least. Like if you look up their nose, you're like, oh, I bet you can't even breathe out of that left-hand side. They're like, oh my God, you're a wizard. Like at least then you kind of have moved the patient to sort of trust you more. And it's one of those things where someone comes in with a headache, palpate their head. Like if you're not going to do anything else, at least pretend like you're paying attention to the area of interest. And I feel like the patient will feel like you're doing a super duper exam too. So just in terms of patient engagement, I like the otoscopic
And you
exam.
can find things that you don't expect. And I think that's probably the bigger part for me is most sinus rhinitis, obstruction is pretty benign, but every now and then somebody will look in the nose and go, I don't think that looks normal. And it's not. And so if you've looked in the nose and, all of a sudden you see this fungating mass, that gets people's attention because you've been looking at the nose the whole time. So That's why I like it.
I wanted to know, Paul's question was about, viral versus bacterial, just from the history and the exam. Can you talk a little bit about that, or how do you, maybe even better, how do you talk to patients about that? And you can talk out loud to us like you're talking to a patient.
So the first thing I tell people is that I can't tell you right now if it's viral or bacterial, because there is an early bacterial that's going to look just like a viral. There's also a transition component. And so a lot of times the story will be, I started with sickness, my kids were sick and I got this congestion and a runny nose, and I, felt really sick for 3 or 4 days, and I was starting to get better, and then I got worse. So that's a double worsening sign. What we know from viral infections is that, one, it's going to cause obstruction, and so that can lead to bacterial overgrowth and bacterial infection. 2, it breaks down the normal epithelial processes. It, may make bacteria more likely to stick, but it just messes with the mucociliary clearance process. So you're setting your nose up to be a lovely petri dish because it's got lots of warm snot in there that things love to grow in if it can't do its normal cleaning. And so do I know on day 4 that something's going to become a bacterial infection? No, I don't. And part of that is why we want to treat things symptomatically, and we want to sort of maximize their nasal function so that maybe we don't get it to the point of a bacterial infection. The other thing I will tell patients is that early bacterial infections in an otherwise healthy person, watchful waiting is actually okay. We want to make sure that we're not missing a complication of it and they don't have any of the comorbidities, but bacterial infections will often clear on their own with what we sort of call a sinus, a good sinus regimen. And so, using a sinus irrigation, symptomatic treatment, all that kind of stuff. And so that's kind of the way I talk to them about it. Granted, usually by the time they're seeing me, they've probably already had this conversation a couple of times. And so if I see mucopus, I'm going to put them on an antibiotic most of the time.
Yeah.
Probably all the time. So
a couple follow-up questions. Is there a sinus toilet? And this is a question that just occurs to me now. Is that what you're going to say? Like a pulmonary toilet, but for sinuses. Is that how you refer to it? Or is
I call it a good sinus regimen. And so,
okay,
yes.
That's probably better.
Yes. Yeah. Well,
Okay.
I mean, you can
It's
call it
less
sinus
gross,
toilet.
Paul.
And I guess...
I have a standard that I'll have people on if they're sick, just to try to, maximize the outflow tracts. And it's, nasal irrigation, just like everybody hates and loves all at once. And we can talk through some tricks and tips if people have had a hard time getting people to use it. I'll usually put them on an oxymetazolam regimen for 3 days, twice a day, sort of scheduled, just to thin everything out. And then nasal saline in between. And that sort of sinus toilet, sinus regimen seems to help a lot with folks just from a symptomatic standpoint.
So I just want to recap that because that sounds important. So you're having them do sinus irrigation. You're having them do the one I can't pronounce, oxymetazoline?
Oxymetazolam.
Okay, I did it. USA. So you're having them do that no more than 3 days. And then you're also having them do sort of saline rinses as well, in addition to the irrigation. And that's sort of your regimen for the acute presumed viral.
So I consider an irrigation and a rinse sort of the same thing.
Okay.
Yeah, which kind of delivery system do you like? Because they make the bottles where you can just, plug one nostril and spray it up there. And then they make the pots where you insert the pot into your nose and then pour, and then water comes out for the next hour, which I've done. And it does seem to work.
So I think both are useful. Patients will have a preference. In general, I'm going to start somebody on a low pressure, high volume irrigation, like a bottle. And the reasons for that is sort of twofold. One, I'm trying to get a lot of the snot and the goo out, and I'm trying to thin it out. The downside of like the neti pot, which is sort of the classic tilt your head, is one, if you're acutely sick, a lot of times it really doesn't come out all that well. And so if I'm using this in an acute setting and I'm trying to get somebody to want to use this long term, then I need to have it work. Some people really love a neti pot, and if they've been using it for years, I'm not going to stop them from using it. But if they've never used something before, that's this sort of high volume, low pressure delivery mechanism is, to me, very helpful. And again, that's sort of in my practice. But the way that I describe it is there's not a lot of downside to it, and it does have some pretty good data that it can help.
I think since we're going to be talking about a lot of nasal sprays, maybe you can tell us how you use the saline nasal spray, and then how that you would instruct the patient to use the oxymetazoline, which is like the topical decongestant.
So in terms of just the saline spray, I kind of tell people they can use it almost as much as they want. It's salt water. There's no sort of overdosing on salt water. It will help with thinning things out. I really like it for folks that have a history of epistaxis, especially if I'm putting them on a nasal steroid. So I really want them to use it. I tell them, every 3 hours while you're awake, but you really can't overuse it. That one's almost more of a maintenance. The value of using it in the middle of an acute infection may be less helpful, but it doesn't hurt. The oxymetazolam, I will have people use twice a day, kind of almost no matter what, for 3 days. They can stretch it to 4. Because what I'm trying to do is I'm trying to thin out the lining so that the sinus irrigation that I use afterwards will get in all those places. So I want them to spray the oxymetazolam, wait 5 minutes, and then I want them to use the nasal irrigation. Does that answer your question?
Absolutely. Yes.
And I feel like what I have a weird and unaccountable love for intranasal fluticasone for some reason for almost any setting. Is that something that you advise patients, or is the evidence so scant for?
So I love intranasal fluticasone for allergy and for any sort of sinus congestion, sort of that's on the chronic edge. When we start talking, less than 4 weeks acute, greater than 12 weeks chronic. When we're talking chronic, I do love it. There is limited data, and I usually will refer folks to the Academy of Otolaryngology guidelines. I think the most recent one was like 2015. There is some limited data that it can help in an acute setting. The big challenge is it usually takes 15 days, which
hopefully they'd be better.
They're usually right. You're usually getting better by then. But there is certainly a role for it. I tend to not use it in my practice unless I'm doing a chronic, but also remember the people coming to me are usually having chronic issues, but I love it for chronic.
Do you ever go to like the intranasal antihistamines or intranasal ipratropium during like an acute? If this Mr. Linus came to you, would you ever go to one of those if he says, "Oh, I hate the oxymetazoline," and you had to go to something else for acute?
I might use a nasal steroid with the caveat that it's probably going to take a little bit of time to work.
Yeah. Unless
I had a strong feeling that this was going to be an allergy-mediated process, the intranasal antihistamine is probably not super helpful. Mm-hmm. I always tell people, we can try it. I try to try one thing before I try the next thing. In an acute setting, usually they've gotten better before we've tried the next thing. Ipratropium is actually a great medicine that I use a lot, but I usually use it as a second line. It's awesome for vasomotor rhinitis. And so folks that get the runny nose when they eat or when they're outside running or when they're cold, it works really, really well for that. I will try both on occasion with folks, but it's not usually my first line. It's usually my second line. But yeah, I'll absolutely use it. And that one you can use like every 6 hours. And so some people like it just because they can use it more frequently.
I have 2 more nasal spray questions, then I promise we can move on from this case. So I
love nasal sprays. This is my bread and butter.
So the first, just so we can say it out loud and be explicit about it, why do we limit the oxymetazolam use? Why are we telling patients 3 to 4 days? Why can't they just use it forever? Because it feels so good.
It does, and it's because your body relies on the ability to have constriction with the sympathetic tone, and so when you spray the oxymetazolam, it causes your nose to quote unquote become addicted to it, so it can no longer decongest without it, and so your normal sympathetic responses kind of go away. And when you spray the oxymetazolam, it fixes it for a little while and then it wears off. And they can no longer constrict any other way. And it's not easy to get people off of it. We actually almost treat it like quitting smoking in some cases in terms of getting them to quit. It's hard.
It's awful. It's
yeah,
awful.
it is. It's hard. It's hard.
I wonder.
Oh, and say the name, because it's the best part about. I mean, it's why you go into. It's that and neuralgia paresthetic are the two reasons you go into medicine, and so you can say stuff like this. So.
Rhinitis medicamentosus. I always have to Google it to make sure I get all the syllables in when I put it in my note.
It's such a great term. I think.
And then the second.
Oh yeah, go.
The second nasal spray question, and I promise we're done with this topic at least until the next part of the case. Do you give any instructions for positioning? Do you tell patients explicitly go up the nose, go back towards the throat? How do you tell patients to actually squirt the stuff into their face?
Sniff as hard as you can?
No, don't do that. So for oxymetazolam and nasal saline, I don't usually. I do spend some time with the intranasal steroids, and that's mainly because those are the ones that if you use it incorrectly, you can cause some epistaxis, and now I've either not benefited them at all or I've changed, I've traded one problem for another. So what I will tell them, and I'll actually use the otoscope little speculum to demonstrate it, but I tell them to aim straight back and slightly out to their cheek, and I'll demonstrate it on me with a plastic speculum, and then I'll have them replicate it themselves, and then I'll position their hand. But it's really straight back, and they should almost feel it on that inferior turbinate. If you see them push it in, and their nasal ala is flaring out because they've pushed it so far in, then they've not gone far enough back. So it's really mostly back.
And
I'm trying to get on that inferior turbinate.
And my bad joke about the sniff as hard as you can. I know that some of the instructions say sniff gently, because if you sniff really hard, it brings it into the posterior pharynx and just totally misses the mark. Is important? Is that really a thing?
I don't know the answer to that.
Okay.
In terms of whether anybody's tested it. Many people don't like the taste or the feeling of it, and so I tend to not have them sniff hard because they just don't like the way it feels or smells. If you get it on the front of your nose, the nasal mucoid or the cilimucoid process will push it to the back.
Okay.
And so it's not so.
It's going to get there anyway.
Necessary. It's going to get there. I mean, that's if you put a little bit of saccharin in the front of your nose, you'll eventually taste it in the back. It works. And so I'm not as worried about people getting it to the back, but they tend not to like it if it gags them or tastes bad.
So it sounds like the main things we're doing for this acute rhinosinusitis is saline and a topical decongestant, and then there's not really systemic pill medications that are part of your first line.
Not typically. I think people talk about whether a decongestant would be helpful. Certainly with the risk benefit of whether it's worked for them before, whether they can, tolerate something like a pseudoephedrine, but all of it is symptomatic treatment. So,
okay.
I don't have a cure for it. It kind of has to write itself out.
All right. Paul, should we go on with the case?
Yep. Great. So we treat Mr. Linus, conservatively. We treat him for a presumed viral sinusitis, or rhinosinusitis, I should say. And then he comes back 5 days later, slightly irritated because he's feeling much worse. On exam, the mucus is thicker. It looks sort of just grosser and is not as clear as it was before, and it's now a light yellow color. If you look at his posterior pharynx, it just looks more irritated and inflamed. So now it sounds like we're crossing possibly into the land of the bacterial rhinosinusitis. And so I'm wondering if you could talk us through sort of what your approach is. I guess first of all, tell us how the patient typically looks different with an acute bacterial infection as opposed to an acute viral infection. And I guess we can take it from there.
Sure. And so I think a lot of it goes down to that nasal exam. And some of it will also be on the history. The things that are very telling for me are I have this sour smell People will actually describe that something smells bad or they have a bad taste even sometimes. And then they'll blow their nose. They will put it in a tissue and bring it to me. I don't know if they do that to you guys or not.
Absolutely.
But that's very common. But it's more of a sort of yellowy, purulent look to it. And then when you look in their nose, again, that middle meatus between the middle turbinate and the outflow of the maxillary sinus, you'll see this like thick, purulent goo. They are usually more uncomfortable. And that story of maybe I was getting a little bit better and then I got worse again, or it's been going on for like 10 days. Those are the two things that I kind of look for. Again, I don't do a lot of tapping on faces. If they describe specifically a certain spot, that's helpful maybe, but it doesn't change my management.
I know the Odo HNS, is that the preferred term for these
that's
guidelines?
What I use.
Yeah, no, that's cool. I want to be.
I don't know if that's the preferred term, but that's what I use.
Look, I mean, you're talking to two guys that went into internal medicine, so anytime we can look cool, it's rare. So the Odo HNS guidelines, they mention this 10-day cutoff, this magic 10-day cutoff, or the double sickening, which you already mentioned. Do you recommend that our audience go by that? Like if they're seeing someone before 10 days and unless there's clearly double sickening already, that they kind of press on with this, they give them the first line stuff and they don't talk about antibiotics until they've failed that or had this double sickening?
I do. And part of it is because, we know that a component of folks who have bacterial sinusitis are actually going to get better even without antibiotics. Mm-hmm. We know that a lot of these are viral that will get better on their own. And so if you can minimize the number of people that are exposed to antibiotics, that's always a good thing, right? And more than that, if they are going to have a chronic sinus sort of pathway, I kind of need to know how many times they really need to be treated and how many times they've just been treated because that's what was easiest, if that makes sense. Because in the back of my head, again, I'm always thinking about what pushes us to surgery. If somebody's been on antibiotics 4 times in a year, I'm like, maybe that's somebody that might benefit from surgery for acute recurrent sinusitis. If somebody has been on antibiotics because every time they go in and they've been sick for 3 days, they get another course of antibiotics, that sort of skews it a little bit. So those are the reasons that I do. I tend to not do a lot of antibiotics first line. I will often give people a prescription and say, fill it if you're not better in 5 days. Or I'll have them call me and I'll put it in at that point.
And so let's just say like we are just rabid about stewardship and we're like, just walk it off, champ, rub some dirt on it. And we just assume that it'll go away eventually. Like what's the worst that could happen to poor Mr. Linus if we just decide not to treat? What can go south if we don't treat the bacterial sinusitis?
Yeah. So it's, yes, there are absolute risks that, for untreated bacterial sinusitis. So we always talk about the orbital risks. And if you want any first year ENT intern to sort of cringe, ask them about the Chandler classifications, which are sort of the orbital complications that we talk about. And, it can go from preseptal cellulitis to an orbital cellulitis to an abscess, even up to cavernous sinus thrombosis. And so those aren't things you want to mess around with, right? Also, an abscess anywhere in the sinuses can progress. I always tell people sinus surgery is high value real estate because it's near the brain. So you absolutely can get meningeal impact. You can get interparenchymal abscesses. You can get Pott's puffy tumor. When was the last time you heard that one?
I've never heard of that one.
Oh, okay. So that is a potential rare complication. I've seen it all of once, and so it's certainly not something common, but it's a complication from a frontal sinusitis that causes an osteomyelitis that sort of breaks through the frontal sinus bone and creates this big puffy tumor literally on their forehead. And so none of these are things that you want to completely ignore in our.
I hope you've never seen that.
I have seen it once.
Paul looks incredulous.
How quickly does that happen? Like
it's not fast. It's not
just
fast.
Do a saline rinse. Don't worry about it. Then they come back to your office 2 weeks later with like this fungating mass coming out of their forehead. Like good God.
It's not a common complication by any stretch of the imagination. But yeah, so you don't want to completely ignore them. And I think that's part of it, is that this requires a relationship with the patient. They have to trust what you're telling them, and they have to trust that they can get back with you if things get worse. And I will often, again, I'll have them call me in a week, I'll call them in a week and see how they're doing, and see if we need to add an antibiotic, or again, I will give them an antibiotic to fill in 5 days or something like that. So it's not something that, everybody should rub dirt on it and walk off.
Okay.
But a lot more people can rub dirt on it and walk off probably than we're currently treating. How's that?
And we're probably talking about the average risk patient, not like uncontrolled immunocompromised condition, like they're actively getting chemotherapy or something like that.
Correct. Absolutely. Yeah. Immunocompromised, you would not, consider by any stretch an otherwise healthy person who gets a couple of sinus infections, quote unquote, a year.
And since I want to keep saying it, the OTO-HNS guidelines mention that you now have the option of 5 to 10 days of either a MOX or a MOX-CLAV, and it seems like it's dealer's choice how long you continue it. Can you tell us, how do you talk to patients about that? What would you recommend we do?
So it does talk a little bit about a MOX-CLAV, whether you would use it in certain patients over 65, patients that have failed amoxicillin first line already, some of those kinds of things. There's more severe symptoms, maybe consider a MOX-CLAV versus amoxicillin. I am more likely to do a 10-day. And part of that is because often at the end of it, I'm going to get a CT scan to see what their underlying bony structure is. But again, somebody coming to me has probably had a couple of these before you've seen them for the first time.
Yeah.
I'm more likely to do 10. I think it's very appropriate to do this 5 to 10, and your patient population may be more comfortable with one or the other. For the same reason that we chose 5 because we've got 5 fingers, and 10 because we've got 2 hands, and 7 days in a week. There's a bit of variability, but I'm more likely to do 10 for the reasons that I described.
Paul Sachs, a friend of ours from Podcast World, is an infectious diseases doctor who wrote probably one of the funniest pieces of medical writing I've ever read about the antibiotic. And he said it has to be a multiple of 5 or 7. And if you want to freak people out, you got to do take a 9-day course of this.
Yeah, an 11-day course. Yeah.
Yes. It's okay. So we're going to do 5 to 10 days. And to remind the audience, if people are making it to Dink, it's because they probably had this recurrent acute sinusitis multiple times. It's not their first rodeo. If you're seeing a patient that otherwise looks totally healthy, but they meet the 10-day criteria or double sickening, 5 to 10 days, you're not recommending we get CT scans on all those folks.
No,
okay.
No. To be very clear, not at all. And I don't. The OTO-HNS guidelines say this, and I tell this to my primary care folks when they call with recommendations. I generally prefer people don't get really any imaging. Use the history, use your physical exam. But an acute sinusitis on a CT scan is going to look terrible, but it's not going to tell me whether the person needs surgery or not. It always looks terrible.
I see. So you want to see what it looks like in the once they've cooled off.
In their best state. Yeah. I tell people I want to see your CT scan on your best day.
Okay.
So for this particular case, let's say we treat Mr. Linus appropriately, and he comes back with persistence of symptoms. So, or actually, why don't I say it a different way, because I feel like there's a little bit of a differentiation here. Let's say the symptoms failed to improve. I think that's a different way to say it. What would you extend the course? Would you try a different antibiotic? What is your approach for someone who does not respond at all to your initial antimicrobial therapy? So
you've done amoxicillin or amoxiclavulinolate for 10 days, and he comes back and he says, "I'm not any better." Is that okay? And he's otherwise doing okay. His eye isn't swollen. He doesn't.
Right.
Okay.
Right.
We don't have any red flags. Okay.
No.
He's just not getting a whole lot better. So second line, I will often use doxycycline. And there's some pretty good data for doxycycline. So 7 years ago, I would have said, a respiratory fluoroquinolone. And I use those a lot. And I have pretty much changed my practice to doxycycline twice a day because it has anti-inflammatory too. And I will, for those patients, they're usually going to have a doxycycline plus or minus a prednisone burst. And then see where they land. And at the end of that, I will get a CT scan because now I've maximally treated them. If I'm not getting better, I need to know why.
The prednisone, can you talk a little bit more about? So that's for people who have failed with an acute rhinosinusitis. They failed the first line. They're getting antibiotics. and you may give steroids along with the second time. I sort of missed that. But in my defense to the audience, they're not on Zoom with us, Paul. A black cat walked by as she was giving the answer.
It's very distracting. Yes. So, and again, I have to sort of parse out my patient population. But yes, if somebody has had a course of a first line antibiotic and they have not gotten better, I will, as an ear, nose, and throat doctor, I love steroids, and I think that's pretty universal. Sure. Universal within ENT. I haven't done a survey, but we tend to love steroids. I will use doxycycline plus or minus a prednisone, and part of it is because doxycycline does have some great anti-inflammatory responses, but it takes a little bit longer. And a prednisone, 1 week burst will sort of give them that week, and then I'm going to do like a 14-day or 21-day course of the doxycycline. And then I'm going to get a CT scan because I want to know what the underlying issue is.
So you might do something like a 40 milligrams for 5 to 7 days, or a 40, and then you step it down, or?
Correct, yeah. And I'll do actually 50, but that's because it comes
in a
easier.
50. Okay, brilliant. No, these are all tips that we need to know. This is great.
But you can do 40. You can do 60.
Yeah, it's steroids, right? Obviously.
Yeah. That's the worst that could happen. But other than the addition of the steroids, is there any change to the symptomatic support that you offer? So you're giving the antimicrobial, you're giving steroids. Do you change anything up in terms of intranasal? Like, would you pull out the ipratropium? Is there anything else that you would sort of add or do differently?
Yeah, I might pull out the ipratropium if I didn't start them on a nasal steroid initially. At this point now we're well into 15 days, so I certainly would, because I wouldn't want them on the oxymetazoline for that long. Again, it's the underlying inflammation that I'm trying to address. But that's, those kinds of, I'm trying to address inflammation. I'm trying to keep the snot balls from backing up and causing a lovely petri dish. Those are the things that I'm trying to make better. And so absolutely the irrigations, absolutely consider a nasal steroid if you haven't already done it. I do tell patients, and they always laugh at me because of course they would never do it, but don't do the steroid or the nasal steroid and then do your sinus rinse, because you just rinsed it all out. Do it the other way around. Versus the oxymetazoline that I told them to do first, right? So it is a little confusing if you're not really clear with them. I might try an ipratropium. I generally use ipratropium though for the vasomotor rhinitis folks or the people who have failed nasal steroid first.
Okay.
How's that for a wishy-washy answer?
Well, it's, I would say, and Paul, I'll confess, and Paul, you let me know if you do the same thing. I think some patients are just pill people. And so I've given antihistamines. I've given, like, patients ask me for benzonatate. And what else? They ask me if they can take guaifenesin, guaifenesin with or without dextromethorphan. And I'm like, sure, why not? I mean, this comes up and people are using it. I mean, the over-the-counter cough and cold supplement industry is just like, it's evidence is sparse, and it's just, they're killing it. I have to imagine they're killing it.
Yeah, and that's often a conversation I'll have with people. Do you feel like it's working for you? Okay, then I'm okay with it as long as it's not causing other issues. And other times they're like, I'm trying this, it's not working. Well, let's stop that because it's not doing anything.
Right.
But again, that goes back to just having these conversations with folks, and folks that have chronic sinus challenges they're in a lot. I mean, there's a heavy disease burden, and every study will say how much the work burden is and the cost of care and all of that. And so they end up being patients that you need to kind of spend some time with and figure out what's really bothering them.
Right. Yeah. A lot of them will complain that they're coughing or they just can't breathe, and it affects their sleep, which is really a bad thing, obviously.
Yeah. Vicious cycle.
Yeah.
Exactly.
This feels like just an excellent time to transition into our next case, who has just an all-timer name. So let's talk about Ethel Moyd. She is.
I love this one so much, Paul.
Strong work, Beth Garbitelli. Ethel Moyd is a 54-year-old female who presents with months of dull face pain and an ongoing runny nose that she feels has been getting worse. She's been trying to manage her symptoms with NSAIDs for the dull pain, and she's been trying her neti pot. She reports that she has recurrent postnasal drip and says she's had times in the past where she's had, quote, bad sinus infections. Her past medical history is significant for eczema and seasonal allergies. She does not note any visual changes at all. On exam, she has a little bit of a deviated septum, and on inspection of the nasal passages, she has bilateral turbinate enlargement with mucopurulent drainage. She also has mild inflammation of the posterior pharynx with copious mucus. Just great descriptors all around. She also, even though we're not big fans of it, let's just say we paddled her face, and she does have some tenderness percussion over the maxillary and frontal sinuses, but no periorbital edema or nothing to suggest an acute scary process on top of all of this. So it sounds like we're transitioning to the land of chronic rhinosinusitis. Can you tell us if this is consistent with most presentations, or if not, where does it vary, and what can we expect to see with that specific concern?
That's pretty classic, and the age range, the sort of it's ongoing. We've tried these things. I really love when they come in having already tried neti pots or nasal irrigation, because that means that we've already sort of established the symptomatic therapy. And I tell people my chronic sinus patients are really going to be on some sort of nasal irrigation lifelong. Even whether we do surgery or not, they're going to be on it lifelong. And so, yeah, she's a pretty classic. I'm always, deviated septum. I don't really worry necessarily that that's going to be a sign that they have more likely or less likely to have sinus problems. It may make it less access for me on a surgical field, but it's usually a deviated septum problem is going to be more like a unilateral obstruction. Not always, certainly, but I don't worry this because somebody has a deviated septum, they're more likely to have a sinus problem. Certainly not one that you can see from the front. So yeah, to me, that's a very classic presentation. And again, it's greater than 12 weeks. And so we're now in that chronic period. And now we need to figure out kind of what else is going on.
And yeah, and to point out I noticed in the Oto HNS guidelines that they, in between 4 and 12 weeks, they leave it up to the clinician to decide if patient is in chronic land or acute land.
Yeah, it's the subacute kind of gray zone. Yeah.
Sure. If you wanted to start doing doing one or the other. What is there many reasons why someone gets into this chronic rhinosinusitis land? What is the believed, pathophysiology or the etiology of all this?
There's lots of them. So they talk, chronic rhinosinusitis with or without polyps seems to be a different disease. As soon as you start asking me what the level of the IL-5 or 4 is, I'm way out of my league for telling you which one is which. But they do seem to be different processes. Folks who have sort of this ongoing chronic rhinosinusitis, they will often have this underlying allergy. And so we try to manage the underlying allergy because, again, it's an inflammation process. But there are lots of reasons. It could be aspirin exacerbated respiratory disease. And a 54-year-old, probably not CF, but certainly in a 20-year-old, you might want to consider it if they've got chronic problems. If you see a teenager and they've got polyps, that's something to think about. So there's the etiology is not small in terms of what the underlying issue is, but there's usually some sort of inflammatory process going on.
And are there specific criteria sort of needed to make the diagnosis? Is this someone that we would send off for imaging? How do I get to feel confident in the diagnosis as just a mediocre internist, let's say?
Absolutely not a mediocre internist. So yes, there are specific diagnostic criteria. And so I'll read them off so I don't miss any of them. So for chronic rhinosinusitis, it's 12 weeks or longer with 2 of the following: mucopurulent drainage, nasal obstruction, facial pain or facial pressure fullness, decreased smell. So any one of those 2. And some evidence of inflammation documented by purulent drainage seen in that middle meatus. So again, looking in the nose with your otoscope to see up in that back behind the middle turbinate. Polyps. So if you haven't seen polyps before, there's some great pictures both in the Oto HNS guidelines as well as there's a New England Journal article that has chronic rhinosinusitis with polyps. And I think if you haven't seen polyps before, you just need to see them once. They look like white grapes is what I tell people, or yellow white grapes, or radiographic imaging. So you need to see some inflammatory evidence in any one of those. And so that's sort of the classic diagnostic criteria.
Yeah, that article, the pictures, the diagrams we're talking about turbinates and the meatus and all this stuff. That article has really great figures in it, and both cartoon figures and actual pictures. So Paul, what are we Are we in treatment territory here now? So it sounds like we really just need to, they have nasal symptoms. They might have pain or pressure in the face. They might have some smell issues. And then we just have to either look with our otoscope or with an image to diagnose this. So what's next, Paul?
Yeah, no, you've sold me on the diagnosis. So I guess now, what do we do for poor Ethel Moyd? Again, a name I cannot get enough of.
So what do you do, or what do you want me to do? I guess.
Yeah, maybe
Well,
both.
Because she's one I would consider for a workup to see if surgery would be indicated, and so that's kind of where we start talking about what's the right time to do a consultation. Certainly you want to try to treat her symptoms if she hasn't been on a course of an antibiotic. It's worth doing, but that's where I start having people, like the folks that refer to me. I tell them, do this, and then I'll get a CT scan kind of thing. And I think that's probably going to be pretty practice specific. In my case, I don't want to get 2 CT scans, so I just want to get the one where I know what condition they were in when they got it. Other places won't see them unless they have a CT scan. So I think that's going to be very practice dependent. But a CT maxillofacial without contrast is kind of our go-to for imaging. Please don't get a Waters view. I don't know what to do with it. I don't know if anybody is still getting them, but every now and then I will get a sinus series Waters view. And I just
Good news is I don't know how to order that, so you'll save from my content.
every now and then I'll get a film of them. I'm like, I don't know what to do with that. But that's kind of where we are next. MRIs are not really helpful. They overcall things. And so, CT maxillofacial without contrast is kind of our next step. And the question is, do you do it before you send them to ET or ENT, or do you wait for ENT to do it?
Well, for this patient...
Ideally,
go ahead, Paul.
I was going to... So ideally, before this patient would get to you, though, she would have perhaps failed a course of antibiotic therapy. She would be on chronic sinus irrigation, is what I'm hearing. And then we'd also, of course, be adding on some of the adjunctive treatments, too. So this is someone for whom it sounds like you would recommend the intranasal steroids.
Correct.
And possibly even ipratropium.
Yeah, and if we haven't done some allergy testing, an allergy workup would be appropriate. And if none of those make things better, then that's absolutely an appropriate patient to send. I will tell you that I will also see them before they have the allergy workup, because sometimes that's how they get to me, and then we'll do the allergy workup. But if you wanted to do the complete workup, it would be, make sure we've tried antibiotic therapy, make sure we've maximized the sinus irrigation. We've looked for underlying allergy. We've considered if, they get exacerbations with aspirin or NSAIDs and are looking for like an AERD kind of process. And then, it's absolutely the time to call an ENT.
Because with this person, she has a history of eczema and seasonal allergies. So maybe she'll in my experience, she would be on loratadine or fexofenadine, one of those medications.
Yeah, and a nasal steroid and
a nasal steroid
maximally treated it. Yeah.
Yes, and hopefully, so we don't know yet if it's allergic or infectious necessarily, but she theoretically failed infectious treatment. And do any of these patients, is there any mixing up, like these patients you mentioned earlier in when we were speaking about the gustatory, people that get the runny nose when it's cold, those people, is that more of like a nuisance thing? Like this is a different class of patient we're talking about here, the vasomotor versus the allergic versus the infectious?
Well, it's the way they describe their symptoms, right? And so I will ask people, because they'll come into my clinic and they'll say, I have sinus problems, or I've got the sinus is really what they say. And so tell me what that means to you. Does it mean I get a runny nose? Okay, when does that happen? Does it happen when you eat? Does it happen when you run or exercise or in the cold? Does it happen every spring? And so, that's where you start digging into those. Vasomotor rhinitis and sinusitis or rhinosinusitis are going to be pretty distinct etiologies. I mean, you can certainly have both, but one of them is very much a kind of, as you said, it's a nuisance, and the other one we may be able to treat with some surgical intervention. I don't know if I answered your question.
No, that definitely answers the question. It sounds like for chronic rhinosinusitis, as long as the people have someone's given it the good old college try, an ENT consult is absolutely warranted, and check your local practice patterns for whether or not you need to get the sinus CT. But make sure, if you're the primary care doctor, my main take home, which I thought was a great point, is try to get their sinuses in the best condition possible before you send them to get the CT. Because if they're already having an obvious major issue, then it's not really, it's not going to be that informative.
Yeah, it won't tell me what kind of surgery would help them.
Okay.
If they're acutely sick.
So one failure I've had along those lines, and I'm sorry to make you revisit this, is I feel like I have talked exactly one patient into saline rinses. Like I feel like just sinus irrigation is a hard sell in general, and I don't feel like I do a good job of explaining it or telling patients exactly how it works or how to perform it. Would you mind sort of going through the specific spiel for sinus irrigation? Because I feel like I've never been able to talk anyone successfully into it. They're like, well, never mind, I'll just suffer through it, which is, I mean,
not at all. Actually, that's one of my favorites. So I have a whole handout. I have, demonstration models. So the things I tell people is that, one, I know that folks who have sinus issues are going to have underlying inflammation and thick snot. And that's what's causing a lot of their symptoms. That's what's causing part of their congestion. That's what's causing that postnasal drip. And so by putting saline, water in their nose, I'm thinning out the snot, letting it go to the back of their nose. I tell them, you make a half a liter of snot a day and you don't feel it if it's thin because you're swallowing it. But if it's thick, that's when you feel it. So I tell them that by putting the saline rinses in their nose, they're going to thin out the snot. So it's not going to bother them as much in the postnasal drip standpoint. It's going to sort of get all the globs out. And so you've got less of the obstruction phenomenon. And by helping that mucociliary clearance, you're clearing out the things that are irritating the nose and causing inflammation. And so that's why it works. So I have a whole handout that just talks about why it works. And then the things that people don't like is that it either makes them feel like they're gagging or it burns. And so then I give them specific tips. And so in terms of the burning, usually it is because the water is either too hot, too cold, or you don't have enough salt in it. And so, they come in little packs generally, although if you Google, people can make their own at home, but you're going to want to put the distilled water, don't use tap water or well water, in the bottle, and you want it to be baby bottle temperature. So 10, 15 seconds in the microwave. Or they can boil tap water and let it cool. Either one. Then you add the salt packet or the salt mixture that they've made at home, and they need to shake it up really, really well. Because if all the salt's at the bottom, it's going to burn once it gets to the less the hypotonic portion of it. So that fixes usually the burning if it's baby bottle temperature and the salt is really well mixed in. The gagging sensation that people don't like is fixed by bending over. I tell them, you really want to be bent over so that you're parallel to the floor. I tell them the first couple of times, do it over a bathtub if you have a bathtub or over the sink. And I tell them, you're going to be amazed at how much snot comes out. It'll be just really cool. It works for kids too, because they get excited about having snot come out of their nose. And you're going to gently go up one side. It's not a pressure washer. You're going to go up one side and you're going to watch it come out the other. If you feel like it's going down the back of your throat, bend over farther. If you still feel like it's going down the back of your throat, they can open their mouth, but they can also make the k sound because that'll close the back of their palate. And with that description and please try it at least 3 times before you tell me you absolutely can't do it, I can get most people to do it. I can get kids to do it. There's YouTube videos. You can Google them. The youngest kid I've been able to consistently get to do it is 4, but it just takes some talking, and those tricks will usually work. For me, hearing that sort of language that we can use and these kind of tips is just invaluable, because we have these conversations every day, especially around this time of year. So this is just fantastic, and we'll make every effort to get some of these handouts that you're talking about and videos curated for our audience to include in the show notes. Yeah, I'll find there's one of the handouts I have actually has a YouTube video from a couple of ENT physicians that they actually do it on screen. Oh yeah, that's great. Paul, I think we have one piece of a case left here. Did you want to do the honors?
I feel like I think you just want to do this one because of the name, which
I heard that you came up with this name, by the way.
That's, which I can never remember what's the difference between libel and slander, but it's one of those. But so let's talk, let's talk about Snotty Pippins, who's a 32-year-old male. He's presenting with a month-long episode of sneezing, runny nose. He's having itchy and red watery eyes, and he just feels kind of tired. He just recently moved to this part of the country, which has a lot of plants and relatively dry weather. He moved in with his partner who owns a cat, if that's helpful history. The transition has been difficult, so he's recently prescribed an SSRI. He's also been using over-the-counter nasal sprays, although he's not really sure which ones. He just kind of picks up like the sinus one, and it's been squirting up his nose. And he doesn't think that it's actually been all that helpful at this point. Maybe it helped initially. On exam, the posterior pharynx shows cobblestoning. He's got this postnasal drip of clear mucus. His nares and nasal passages are inflamed, and his turbinates are bilaterally slightly enlarged. His sinuses are not tender if we choose to bang on them. And there is bilateral conjunctival injection and maybe some mild infraorbital edema. So it sounds like we're trying to sort of sell you on a patient who's having possibly allergic rhinitis. So I wonder if you wouldn't tell us sort of your initial thoughts on this patient, how your workup and sort of management would begin.
Sure. Yeah. So the patient does have all the classic hallmarks of an allergic rhinitis. But the physical exam findings, that clear rhinorrhea, the sneezy, I tell people if it's itchy, scratchy, sneezy, it's allergy to me unless proven otherwise. I need to prove that it's not allergy before I start looking for other reasons. So itchy, scratchy, sneezy, the timeline, and oh, by the way, we've moved and we're around a cat, and we perhaps haven't been around a cat before. So my first, just in questioning, I do want them to tell me what over-the-counter they're on, and even the brand name, and I will Google it and figure out whether it has oxymetazolam in it or not, because a lot of them do, and it's just not really clear that they do, because that's going to send me down a slightly different path if we've got more of a overuse of oxymetazolam versus an allergy, and maybe you have both. So I would absolutely get some sort of allergy testing. I would absolutely put them on a nasal steroid if they have not already been on a nasal steroid. And if they have been on a nasal steroid, I'm going to make sure they're using it correctly and consider adding nasal antihistamine. Because a lot of times people haven't been even, I tell people, the two most common errors I see are that they try to put it straight up their nose, in which case it gets caught in this little corner like a booger catcher and just drips out. Or they're aiming towards their septum, in which case it's just causing a nosebleed and it dries their nose out. And so I usually will have them at least try nasal steroid if they haven't already been on it for another 4 weeks. And if they have and they're using it correctly, I'll add a antihistamine nasally. And then, allergy testing, and then we kind of go from there. Other things that are, the cobblestoning to me is very helpful, although you also get cobblestoning with reflux. And people can complain of almost a postnasal drip congestion sensation with bad reflux too. And so I may ask that in the history. But yeah, the itchy, scratchy, sneezy is going to be allergy workup until I prove that it's not.
I promised Stuart I would ask this. He worried about theoretical tachyphylaxis with someone taking nasal steroids all the time. And I think he has patients take intermittent breaks and maybe only take them a certain number of days a week. Is that something that you subscribe to? He admitted that this is not something that he's ever been able to find a trial looking at.
Sure. So I don't worry so much about tachyphylaxis typically. Now, I do have patients that I know they're only allergic to grasses, and so I will have them only use it during the summer. Mm-hmm. And so that's why allergy testing is helpful, because we can sort of guide the use of it. I do want them to take it for a minimum of 4 to 6 weeks every day before I decide if it's working or not. I have not gotten to a point where I've told anybody to do it for 5 days, then not do it for 2 or something like that. I have switched nasal steroids, and I don't have a great reason as to why sometimes it works and sometimes it doesn't. But I have taken people who've been on fluticasone and put them on budesonide. There's no great reason why one should work better than the other, but I have switched people. But often, if I'm not successful with just a nasal steroid, it's usually because they need something else in addition to. So I haven't seen it in my practice, but again, I haven't been in the literature to answer that question. I may have to take a look up on that one.
The other thing that is constantly, we talked a little bit about systemic medications, and other than we talked a little bit maybe antibiotics and steroids at some point for the acute rhinosinusitis, we haven't really talked about oral medications much. And I know people are really, for allergic rhinitis, people are commonly on these, like the newer antihistamines. What do you think about that and their comparative efficacy with like intranasal steroids or the topical antihistamines?
Sure. And so so intranasal steroids are in most guidelines and studies that I look at are sort of first line. And part of that is because there's two components of the allergy, right? So you've got the congestion part that's sort of the ongoing inflammation. And so the nasal steroids work at the point of that congestion. The itchy, sneezy, runny, itchy eyes piece does seem to work better with the over-the-counter. And so that's the way I will describe it to people. I will say, I want you to be on the nasal steroid because that's going to help with that inflammation, that congestion feeling. But on the days that you're particularly sneezy or the runny is more problematic, then you can use the antihistamines almost like a breakthrough.
Mm-hmm.
Some people end up using it every day, and that's okay because that's their majority symptom. But it's that early itchy sneezy is different than the longer term congestion. The other thing I'll do is I'll put them on an ocular antihistamine because that itchy eye, there is some data that the nasal steroid will help. But the ocular antihistamine will really help. And a lot of times that's the most irritating part of it for folks. And so I ask them what's the symptom that's bothering them the most. But I generally will use it as a in conjunction with a nasal steroid. There aren't a lot of people that I don't put on a nasal steroid. Certainly there are people that I don't, but it's the default unless I've got a good reason not to.
So let's say Mr. Pippins comes back to us in, say, 3 months, and a lot of the allergic symptoms seem better. So like he's no longer sort of itchy, his eyes are okay, but his nose is just running. How does that change the differential for you? What other things should we be considering for someone who has sort of a chronic rhinitis type picture?
Sure. So there's allergic and non-allergic rhinitis, right? And the first line therapy for both allergic and non-allergic is a nasal steroid. When the nasal steroid doesn't work and you have allergy, then I look at other allergy medications we should put them on. If you've done allergy testing, they're negative to allergy, or at least to what you've tested, because it's the other thing I tell people is that you're negative to the things I've tested you for. It doesn't mean you have no allergy. It means you're negative to things I've tested you for. Then we start looking at things like ipratropium potentially. That one is the first one I go to when it looks like more of a non-allergic rhinitis that hasn't responded to steroids. And when they respond to that and it looks in it, then that works. There's some newer potential surgical interventions that might be considered. So that's kind of where I draw that's where I start heading if it's more of a non-allergic rhinitis that hasn't responded to steroids. But the first line for both allergic and non-allergic is still going to be that nasal steroid.
Great.
Well, Paul, I think we're coming to the end here. We've done acute rhinosinusitis, chronic rhinosinusitis. We talked about allergic, non-allergic. Any burning questions?
I think we hit all the high points. I feel good.
So I think now would be a good time, Dink, if you could give the audience some take-home points, maybe recap like your favorite things that you want them to remember so that we can send you and your colleagues like better referrals.
Absolutely. So the first piece is please reach out to your ENT colleagues because a lot of times we can give you some early guidance and there are some practice patterns that are going to be very specific to some areas. Inflammation, looking for the etiology of inflammation is going to be sort of the underlying piece for any of the versions of sinusitis, rhinosinusitis. If you're dealing with acute, there are some very specific things you can look for, whether it's viral or bacterial. And when we start getting into that chronic greater than 12 weeks, don't be afraid to, we've done the nice saline regimen. We've tested for allergy. We've sort of maximized their sinuses. That's the point that it's probably a good time to send them to an ENT. And then if you can get everybody to do their sinus irrigations, that would be great.
Yeah, I'm excited to see. Paul and I are Paul, we'll see. Let's have a contest who can get more people to rinse out their sinuses.
Sure, that feels ethical and good. We should totally do that.
All right. I think we can end there. Thank you.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Yep, sure. Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
And we're committed to providing you with high-value, practice-changing knowledge. But to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts. You can contact us at thecurbsiders@gmail.com. And I wanted to thank our producers for this episode, the great Dr. Paul Williams, Beth Garbitelli, Kate Grant did the cover art for this, and to our social media team, always there, Beth Garbitelli on Twitter, Mad Dog Maddie Morgan on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
And of course, we would be remiss if we did not thank the great Stuart Brigham for composing the theme music that you are doubtless hearing played behind our voices. And we should also thank the amazing Claire Morgan of Not Early for editing our audio. And as always, I remain Dr. Paul Nelson Williams. Thank you and good night.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.